Please welcome back Dr. Joshua M. Sharfstein.
How's it going so far? Okay, excellent. So I remember my first impressions of our next speaker, who is Dr. Rochelle Walensky, the director of the Centers for Disease Control and Prevention. I could tell she was very smart, had a great positive attitude, and was going places. And by going places, I mean I think her mom was going to take her to the Cabin John shopping center. We were in 3rd grade. Now, Rochelle and I remained friends through high school and beyond. I particularly remember 6th grade because Rochelle was the tallest kid in the class, and I was the shortest kid in the class. And Rochelle did go places. She trained in medicine at Johns Hopkins before moving to Harvard to study infectious disease and focus on HIV. She became not only a leading researcher, but also a leading advocate for equity and access to treatment, and particularly treatment for women all over the world. At CDC for 2 years, Dr. Walensky has held, in my opinion, the most difficult job in public health ever. She has stood tall in a storm of misinformation. She's begun the difficult work of acknowledging shortcomings and fixing the CDC, and she has spoken with honesty and integrity again and again to the American people. Please welcome Dr. Rochelle Walensky, someone I have looked up to both literally and figuratively for a very long time.
Wow, good morning. I am delighted to be here. Thank you, Dr. Sharfstein, for the invitation to speak, for your leadership as the Vice Dean of Public Health Practice and Community Engagement at the Johns Hopkins Bloomberg School of Public Health, and for your leadership as a key member of CDC's Advisory Committee to the Director, helping our agency prioritize our activities, address health disparities, and chart a bold course for the future of public health in America. I am honored to have called you my friend, truly, yes, since, well, I would say the 2nd grade. I think Josh said the 3rd grade. I've been referring to the pandemic as the Superman moment of public health, our Superman moment. In the spring of 2020, we were going about doing the good work of public health. Then, a dizzying moment. We were called to enter the phone booth, to don our capes, and to emerge with the tools to fight COVID. The spotlight was on us. And while we had knowledge and we had experience, we didn't have all the answers. But in our figurative capes, we, the public health community, stood together to confront the most enormous public health challenge of our lifetimes. Indeed, I believe this COVID moment that demonstrated the importance of public health, our added value, our steadfast nature, our quiet expertise, is what is motivating so many more people to enter the field, energizing the next generation of public health leaders. The challenges of the COVID-19 pandemic made us acutely aware of the urgent need to create public health culture that is nimble and one that puts health equity at the forefront of our actions. I want to spend the next few minutes talking with you about the subject of data, the essential foundation of good decisions. Public health is a data-driven effort. Data must move at the speed of need, not at the speed of bureaucracy, especially in times of crisis. We must have timely and quality data to monitor disease levels, to track and analyze health trends, and to measure the results of our interventions. Now, while everyone is watching, we must take advantage of that attention and put in place the changes that are needed. At CDC, we take very seriously our responsibility to analyze and share data quickly, to transparently share the data upon which our decisions are made with our public health partners and with the American people. but we can only report the data we receive. CDC does not have direct authority to require data reporting. Headline after headline calls on us to report information on X or on Y. But let me say it again. CDC does not have direct authority to require data reporting. We receive data from 50 states and more than 3,000 local jurisdictions and territories. Each has its own data sharing agreement with the CDC and its own data sharing agreement sometimes with each other. It is up to each city, county, state, tribal nation, and territory to decide what information is collected and how it will be shared. Then the data arrive at the CDC in a variety of formats, from automated electronic data exchanges to Excel spreadsheets to forms on paper. And the speed at which the data are delivered varies because each jurisdiction has its own systems and capabilities, and many are quite antiquated. Some are still working on 1980s fax machines. All of this must change. For example, real-time data on firearm-related injuries, including information on the intent, location, relationship to the shooter, and circumstance, is critical. Yet, CDC only has the authority to aggregate data at the national and regional levels, not at state or local, with some few exceptions. We have no statutory authority to require data collection on youth risk behaviors or evidence-based school health policies and practices. Without this authority, it's a struggle to get full participation and the data needed to develop programs supporting the health and well-being of our students. Recommendations on how to change poor health outcomes caused by conditions such as hypertension and diabetes are hampered by data that come to us slowly, sometimes months or even years after they are collected, and without information in all of the fields. And when we face the Mpox outbreak and our public health partners and public expected CDC to rapidly report on who was being vaccinated and how many cases were being reported, our lack of data authorities meant our state, local, tribal nation, and territorial partners were not required to provide us that information quickly or even at all. I've spent considerable time on the Hill speaking with members and promoting the recent legislation introduced by Senator Tim Kaine and Representative Lauren Underwood that will provide CDC and public health writ large a modern policy tool to create uniform data standards that local, state, tribal, territorial, and federal health systems would all use, providing secure access to data in a standardized, timely, and coordinated way. This will mean better data, faster data, and reduced burden on data providers. CDC's Data Modernization Initiative is working to modernize our technology while putting the right people, processes, and policies in place to deliver real-time, high-quality information. Our Data Modernization Initiative is about making sure our data highways connect and that the traffic is free-flowing. At the beginning of the COVID-19 pandemic, we had no national system for tracking positive and negative laboratory test results. So we created a new pathway for laboratory data through COVID electronic laboratory reporting, capable of delivering more than 1 million test reports per day. Keep in mind, before COVID, reportable diseases came to CDC at the frequency of a measles or Legionnaire's outbreak. When we began collecting data on COVID cases, only a handful of healthcare facilities were even capable, of sending electronic case reports. Now, thanks to our partnership with the Association of Public Health Laboratories and the Council of State and Territorial Epidemiologists, more than 20,000 healthcare facilities across all 50 states are exchanging automated, near real-time critical patient data with our national public health jurisdictions. And while this is amazing progress, 20,000 healthcare facilities is only a fraction of the total, representing only 22% of the hospitals registered for the Centers for Medicare and Medicaid Services and 9% of rural health clinics. We have much more work to do. Cloud-based platforms give us the capability to deal with the millions of lab records received each day. The more than 530 million unique immunization records processed in the past year, the almost 2 million SARS-CoV-2 sequences, all numbers we have not seen in the history of public health. We want these data to come to CDC quickly, and when they do, we want to deliver them swiftly back to you so that you can see what is happening in your area and, importantly, the areas around you. We're improving the data collection of equity-related data. For instance, our ability to capture race data from COVID-19 related emergency department visits has grown to 93%. And we continue to work with hospitals and onboard new hospitals to continue to grow that number. Data from emergency department visits are important for monitoring public health events that would otherwise present to an emergency department, not just COVID, but influenza, RSV, Mpox, many other infectious diseases, overdose and other injuries, suicide attempts, heat-related illness, and so much more, and how patterns vary by demographics, they vary by time, and they vary by geography. We're adding modules for social determinants of health to our surveillance systems for behavioral risk factors in pregnancy to help us track topics such as food and housing insecurity, transportation access, social support, well-being, and economic stability. And in a way that absolutely protects personal identifiers, we're collecting more specific non-health data on smaller populations that have historically been underserved and underrepresented in the data. For example, using vital statistics and census data to develop a mortality profile for American Indian and Alaskan Native communities. As you say, data modernization is not just for outbreaks and pandemics. To help us use data to identify and prepare for future threats and to translate and communicate what we are learning more effectively, in August of 2021, we launched the Center for Forecasting and Outbreak Analytics. This new center is strengthening the nation's early warning systems for health threats, bringing together next-generation public health data, expert disease modelers, public health emergency responders, and communication experts to work towards never facing another public health emergency unprepared again. We have had a very hard 3 years. And when we started, we were undervalued, misunderstood, and frail. And yet, I see this as an incredibly exciting time for public health. Our public health community is using this momentum provided by the pandemic to build a public health workforce and system prepared for the challenges to come. Not only by developing and deploying world-class data and analytics, but by investing in core infrastructure, including maintaining state-of-the-art labs, responding to international and domestic outbreaks at their source, and strengthening our global capacity and domestic preparedness. Now, before I leave you, I'm going to put on my CDC and infectious disease hat and mention that it's National Influenza Vaccination Week. And remind you that if you haven't gotten your flu shot this season, now is the time. And while you're thinking about vaccinations and talking to your family and loved ones and friends, have you received your bivalent booster? Fewer than 33% of those over the age of 65 have gotten their shot. And the number protected with the bivalent vaccine decreases with age, with just over 8% of those 25 to 49 having gotten their updated dose. With the elevated levels we are seeing of respiratory viruses this year, these vaccines can be life-saving, especially for those at highest risk. So it's not too late to get your vaccination. To each of you here today, please know how grateful I am for the work that you do, the effort that you put in, and the commitment that you have to our field, our science, and to the public health mission. Thank you very much.